All right, let's jump right in. Welcome, freshly graduated dentists, to this explainer. Today, we're going to construct a completely foolproof diagnostic clinical workflow. Look, if you've ever felt that sudden knot of anxiety in your stomach when a patient sits in your chair in absolute agony, but the source of the pain isn't immediately obvious, well, you are in the exact right place. We're bridging the gap between textbook theory and real-world clinical mastery.
Before we get our hands dirty, here's our roadmap. We are covering Section 1, the conceptual blueprint. 2, subjective data extraction. 3, systemic risk mitigation. 4, non-odontogenic mimics, and we'll wrap up with Section 5, the digital transformation. It's like a giant puzzle, and we're going to ensure every single piece fits perfectly.
Starting off with Section 1, the conceptual blueprint, the art and science. We have to start at the absolute foundation of our clinical existence, which is the underlying philosophy of diagnosis.
Here is the absolute crux of it all. Diagnosis is the art and science of detecting deviations from health to determine exactly what the problem is and why it's occurring. As a master clinician, your ultimate, non-negotiable objective is to answer that what and that why before you even think about recommending a treatment or picking up your handpiece. Honestly, no appropriate treatment can happen until all those whys are definitively answered.
So let's break down the mechanics. These are the 5 stages of diagnosis, and they form your systematic investigatory process. Now, gathering objective facts, that isn't enough. Actually, scratch that. It's practically useless unless you interpret those facts through an active dialogue with your patient. You start by truly listening. Then, you question, you run objective tests, you correlate those findings, and only then do you formulate your definitive diagnosis. The art of listening and the science of testing, they literally cannot function without each other.
Moving right along to Section 2, subjective data extraction, crafting the narrative. This is where we play detective, relying on the patient's own words to guide our clinical testing.
When the patient first arrives, capturing their raw, unbiased chief complaint on a structured symptom form is your very first critical clue. You want their exact words. Without these direct, completely uninfluenced comments, you might end up going down a rabbit hole and finding a dental pathosis that has absolutely nothing to do with why they're actually sitting in your chair today.
Once you have those initial clues, you've got to filter them through these 5 fundamental pillars of questioning. This gives you the exact chronology of their pain. Localization, can they actually point to the tooth? Commencement, when exactly did this start? Intensity, are we talking a 2 or a 10? Provocation and attenuation, what triggers it and what gives them relief? And finally, duration. Does that pain linger?
Now consider this classic rhetorical diagnostic dilemma. If a patient comes in with severe, blinding pain, but they cannot localize the offending tooth, which diagnostic mechanism are you going to deploy first? When symptoms aren't localized, it completely throws a wrench in your process, doesn't it? It forces your subsequent tests to be highly strategic. You can't just guess. You have to lean heavily on your objective testing sequence to flush out the real culprit.
And that brings us to a massive trap. I want to give you a critical warning against a huge novice bias: guilt by association. A patient comes in, points to a tooth, and says, "Yeah, my dentist just did a fill-in here last week and now my whole jaw is throbbing." You absolutely cannot assume that recently restored or traumatized tooth is the automatic bad guy. You have to resist the urge to jump the gun. You must perform objective verification tests to prove it, every single time.
Furthermore, we really need to weigh the intensity of the pain against its duration. Intensity is often measured by what they need for relief. Are they taking over-the-counter Tylenol, or are they begging for a narcotic? But compare that to duration. If you put cold on the tooth, does the pain subside in a few seconds, or does it linger for minutes? That lingering duration is a real game changer. It often dictates whether you're just repairing a defective filling or gearing up for full-blown endodontic therapy. Oh, and a quick side note, if they've taken painkillers in the last 4 to 6 hours, keep in mind that it can totally mask your diagnostic test results.
Okay, Section 3, systemic risk mitigation, beyond the oral cavity. Let's just pause for a second. We need to analyze the systemic impact of the patient's medical history. Taking this cognitive pause gives us the mental breathing room we need to digest some pretty complex pathophysiological connections.
You must review and physically initial a comprehensive health questionnaire at every single visit. You're gathering baseline vitals because, hey, an elevated blood pressure might just mean they're terrified of the dentist, or it could indicate a severe, unmanaged cardiovascular issue. We're evaluating their health from 2 crucial perspectives. First, do we need to modify our treatment plan? And second, Are we looking at oral manifestations of a systemic disease?
When you review standard medical conditions requiring dental care modification, it reveals a sweeping, almost intimidating range of issues that mandate immediate alterations to how you deliver care. This isn't just checking boxes on paperwork. This is literally about keeping your patients safe. You need to understand precisely why these specific systems alter your endodontic approach. Cardiovascular issues, they might require stress reduction protocols or completely limit your use of epinephrine. Renal failure totally changes how drugs are metabolized, which flips your pharmacological choices upside down. And neurologic disorders or hematologic issues like uncontrolled diabetes, that means your patient might heal poorly or be prone to recurring abscesses. You've got to connect their systemic health to your local endo plan.
Let's dive into Section 4, non-odontogenic mimics, the diagnostic traps. We are now entering the absolute most dangerous territory for fresh grads. Diagnostic traps where systemic issues masquerade as dental pain.
Acute maxillary sinusitis is the classic mimic. It creates incredible diagnostic confusion because it makes the posterior maxillary teeth extremely sensitive to cold and percussion. It perfectly fakes the signs of pulpitis. If you don't ask about sinus congestion or recent colds, you might literally initiate a root canal on a perfectly healthy tooth, all because the patient has a sinus infection. No way do you want to make that mistake.
And these mimics go way beyond the sinuses. Tuberculosis and lymphomas can cause swollen lymph nodes that look exactly like an odontogenic infection. Multiple myeloma can cause totally unexplained tooth mobility. Sickle cell anemia, it causes bone pain and radiographic changes that mimic endo lesions perfectly. And don't forget trigeminal neuralgia, MS, or even referred pain from cardiac angina. Bottom line, if your subjective and objective findings don't neatly add up to an obvious dental diagnosis, you must suspect these mimics and get their physician on the phone.
Finally, we reach Section 5, the digital transformation, legally sound charting. We've gathered all these clues, we've done the detective work, and now we must securely lock it all in.
While traditional paper-based SOAP formatting, subjective, objective, appraisal, and plan, served us really well historically, modern practice management software is a whole different ballgame. It allows for user-defined, automated digital charting. You're using drop-down menus to instantly track and correlate cold tests, percussion, mobility, the whole shebang.
But listen, this isn't just about clinical convenience. The strict legal reality of your practice is that digital charting systems automatically time and date stamp your transactions. Ideally, all that documentation should lock within 24 hours. This is absolutely crucial to ensure diagnostic data cannot be fraudulently manipulated after the fact. It means your thorough, careful investigation is permanently and legally secured.
As we wrap up this explainer, I want to leave you with one major challenge. When you're faced with complex symptoms, a highly stressed patient, and potential systemic mimics, will you have the discipline to definitively answer the why before picking up your handpiece? Trust your data, always respect the medical mimics, and never, ever compromise on your diagnostic workflow. Thanks for joining me on this, and keep asking those right questions.